Good day everyone. In the previous video we have seen the definition of arrhythmia, causes of arrhythmia. Those are two causes, that is defect in potential generation and difference in potential generation. And we have also seen the target of drug action, that is blocking of sodium channels, calcium channels, potassium channels, and increasing the refractory period. And also the classes of drugs that are used in arrhythmia. Those are four classes and one extra miscellaneous. First class is sodium channel blockers, second class is beta adrenergic blockers, third class is potassium channel blockers, and fourth class is calcium channel blockers, and fifth is miscellaneous. And in this video we are going to see the drawbacks of the classes of drugs that are used in arrhythmia, and also the detailed description about each and every class. And coming to the drawback of antiarrhythmic drugs, the main drawback of antiarrhythmic drugs is arrhythmia, ventricular tachyarrhythmias. Ventricular tachyarrhythmias, it is increase of heartbeat corresponding to arrhythmia in the ventricular region. And this ventricular tachyarrhythmias was mainly shown by class 3 drugs, that is potassium channel blockers. And ventricular tachyarrhythmia is also called as torsades de pointes. Torsades de pointes, it is main thing in case of GPAT point of view, so you have to remember blindly that ventricular tachyarrhythmia, it is also called as torsades de pointes. And this is the drawback of anti-arrhythmic drugs. And coming to the class detailed description about the classes, first let us go into the class 1 drugs, that is sodium channel blockers. These class 1 drugs are use dependence, that is they do not act on the normal conditions of the heart, they act only at the abnormal conditions which are showing the arrhythmia, or which where the action potential is differing, that is called as use dependence. And class 1 drugs are again classified into three classes, that is 1A, 1B, and 1C, based on the location they act. The first class is 1-year drugs. These 1-year drugs, examples for 1-year drugs is quinidine, disopyramide, and procainamide. These are the three drugs that comes under class 1A drugs. And these three drugs show their action by blocking sodium channels in open state. The sodium channel may be in either open state or closed state, that is active or inactive. And these 1-year drugs act in the open state. Let us consider a depolarization curve. Here is the depolarization where the action potential starts and entering into synovial node. This synovial node shows fastest depolarization, so the depolarization moves to the positive side, and then slowly the depolarization decreases and enters into repolarization state. In this repolarization state, there is no depolarization, only repolarization, that is the membrane is going into negative charge, and again the membrane undergoes depolarization where initiation of another action potential takes place. This fastest depolarization is called as phase O, and the peak of depolarization is phase 1. Slowing of depolarization is phase 2, and this depolarization is phase 4, and initiation of depolarization is phase 4. This in phase O, sodium influx takes place. Due to this influx of sodium, it shows fastest depolarization, and in case of phase 2, calcium influx, and in case of phase 3, potassium outflux. So it is called repolarization. The class 1 drugs acts at sodium influx phase O, and calcium influx phase 2, and potassium outflux phase 3. They also show a mild action in slope in this change in repolarization, that is slope of depolarization is decreased. This was shown by class 1A drugs. Due to the slow conduction velocity, as the velocity of the action potential is slowed down, it takes more time to initiate the action potential, or it takes more time to travel or re-enter. So that is, it is also called as increased refractoriness. This is the action of class 1 drugs. And main important point in case of class 1-year drugs is disopyramide. Disopyramide, according to KD Tripathi, they have said that disopyramide is used as second line drug for prevention of ventricular arrhythmia recurrence. If a patient is already suffered from ventricular arrhythmia and he is already taking a treatment, and there is some cure in ventricular arrhythmia, if there is any recurrence of ventricular arrhythmia, then a person can take disopyramide as a second line drug which can prevent recurrence of ventricular arrhythmia. Let us get into the detailed description of each one drug in case of 1A class of drugs. First of all, we are seeing differences so that it will be very easy to study and to remember. The first activity is beta adrenergic blocker. Quinidine is the only drug that has beta adrenergic blocker, and it has also mild mild, and procainamide and disopyramide has no alpha-adrenergic blocker and anticholinergic activity. Disopyramide shows more anticholinergic activity, whereas then quinidine shows mild, and then procainamide has less. Negative inotropism. Inotropism is defined as the ability of the ions to pass through, ability of a membrane to allow the ions to pass through. This is inotropism. And negative inotropism means depolarization. Disopyramide has highest negative inotropism, and quinidine and procainamide has weak depolarization and peripheral vasoconstriction and myocardial contractility in systolic heart failure. These two actions are shown by disopyramide only due to the anticholinergic activity and negative inotropism. And therapeutic uses of three drugs is disopyramide shows ventricular arrhythmias only, action against ventricular arrhythmias, whereas procainamide shows action against atrial arrhythmia and ventricular arrhythmia. And in case of quinidine, it shows atrial arrhythmia, ventricular arrhythmia, and AV junctional arrhythmia. These three arrhythmias are cured by quinidine. And alternatives, what are the substituents we can substitute with quinidine, procainamide, and disopyramide? The quinidine and procainamide are substituted by disopyramide because disopyramide has the highest anticholinergic activity, and it also has the ventricular arrhythmias, and it also shows highest negative inotropism. The disopyramide can be quinidine and procainamide can be substituted with disopyramide, and procainamide can be also substituted with amiodarone. Amiodarone is the only class of drug in case of antiarrhythmics which shows all the actions of all the classes in antiarrhythmics. And adverse effects of quinidine are synchronism. Quinidine is a derivative of quinine which is obtained from the cinchona bark. So as it is obtained from the cinchona bark, it highest when used in high doses, it causes synchronism. The main symptoms in case of synchronism is blurred vision, headache, psychosis. And quinidine is also a paraglycoprotein inhibitor. Paraglycoprotein inhibitor. And in procainamide main action is hypotension because it show it is a less anticholinergic activity. As it is anticholinergic activity to some extent, so it causes hypotension. And disopyramide, the main adverse effects of disopyramide is dry mouth, blurred vision, and constipation. These are the main adverse effects, and it is also important in case of GPAN point of view. You have to remember at any cost. And class 1D drugs of class 1A are lidocaine and mixalytin. Lidocaine and mixalytin, the main action, they show action at sodium channels though in inactivated state, whereas in case of 1A drugs they show action in activated state. These 1B drugs show action in inactivated state. The therapeutic uses of lidocaine and mixalytin are both show action against ventricular arrhythmias, whereas mixalytin also show action against a post-infarction sinister of ventricular arrhythmias. You have to remember this post-infarction sinister of ventricular arrhythmias. Infarction sinister of ventricular arrhythmias. And alternatives, with which drugs these lidocaine and mixalytin substituted is amiodarone, or they can also be given in combination with amiodarone because amiodarone has the activity to act as sodium channel blocker, potassium channel blocker, calcium blocker, and beta adrenergic blocker. And the adverse effects of lidocaine are nystagmus. Nystagmus means involuntary movement of eyeballs related to eye, and confusion, slurred speech, and convulsions of fits. These are shown by lidocaine. And these are the adverse effects of lidocaine. Mixalytin, the common adverse effects of mixalytin is nausea, vomiting, etc., etc. You can write. The next class is 1C. The 1C acts mainly in open state of sodium channels, whereas 1A also acts on sodium channels in the open state only. Only the 1B drugs acts on sodium channels in inactivated state. Examples for 1C drugs are flecainide and propafenone. And these are the last two drugs in case of class 1. Flecainide has the actions like it suppresses phase O upstroke in Purkinje fibers, as there is fastest depolarization in case of phase O. This was suppressed by flecainide only in Purkinje fibers, not in the SC node and AV node. And flecainide also shows potassium channel blockers, that is it also acts as phase 3, whereas propafenone, it is also same similar to flecainide, that is it suppresses phase 1 upstroke in Purkinje fibers, but it lacks potassium channel blocking action, whereas flecainide has potassium channel blocking action. Therapeutic uses of flecainide is atrial flutter and fibrillation. I have explained this atrial flutter and fibrillation in the previous video. You can You can watch. And the therapeutic uses of propafenone is atrial flutter, supraventricular tachycardia, and beta blocker. Propafenone is the only drug in the class 1 sodium channel blockers which also shows class 2 action, that is beta blocking activity. And adverse reactions of flecainide includes blurred vision. Blurred vision is the common adverse effect in case of quinidine and disopyramide. Also nausea, nausea we can see in mixalytin, and dizziness is the new adverse reaction in case of flecainide. And in case of propafenone, the main adverse reactions are bronchospasm for being beta blocker. As it is a beta adrenergic blocker, it shows bronchospasm, and it also inhibits paraglycoprotein, same as in case of quinidine. Coming to the class 2 drugs. Class 2 drugs are beta adrenergic antagonists, that is we can also call as beta blockers. Their main action is arrhythmia. It treats arrhythmia of post myocardial infarction. It is very important in case of GPAN point of view which are the drugs that are used to treat arrhythmia of post myocardial infarction. Those are beta adrenergic blockers. Examples for beta adrenergic blockers are metoprolol, propranolol, atenolol, and esmolol. Metoprolol is most commonly employed, and propranolol, then atenolol, then esmolol. The main characteristic of esmolol is it is a short acting beta adrenergic blocker in case of arrhythmia. It also has short half-life, and it shows fastest onset of action. So if a person is suffering from arrhythmia and it takes a while to hospitalize that person, in meanwhile you can use esmolol to decrease the effect of arrhythmia. Atenolol, it has less CNS penetration, so it shows lesser activity. And propranolol, it is it has highest CNS penetration. As it is having higher CNS penetration, it shows high bronchospasm. And this propranolol is also active against sympathetically mediated arrhythmias in pheochromocytoma. And metoprolol, it has lower bronchospasm when compared to propranolol. And these class 2 drugs, beta adrenergic antagonists, are the only class of the drugs that are used to control the rate of arrhythmia, whereas the class 1, 3, and 4, these are used to control the rhythms, but these are the only drugs that are used to control rate. And next class is class 3 drugs. Those are potassium channel blockers. Potassium channel blockers, they act at phase 3 where repolarization occurs. These potassium channel blockers, they diminish efflux of potassium. During repolarization, potassium efflux takes place. This potassium efflux was blocked by potassium channel blockers, and because of this efflux of potassium, they increases the there you can see increase the slope of depolarization, that is increase in AP duration, that is action potential duration. Due to increase in action potential, there is also a increase in refractoriness, and thus they show no action in phase 0, that is depolarization. Only they show action in repolarization. Once again, let us get into the depolarization curve. Here is the action potential, and action potential undergoes depolarization and then slowing of depolarization. These up to second stage it comes under the depolarization, and after depolarization it gradually enters into the repolarization state where the curve slows down and where the potassium efflux takes place, and then again depolarization where the action potential starts to act against. So here in this depolarization state, only the potassium blockers act. Due to this potassium blocking activity, the slope of the repolarization has increased, that is leading to increased QT interval, and it is also leading to increased action potential duration. And the main drawback of class 3 drugs are induced arrhythmias, that is ventricular tachyarrhythmia. This is the only drawback of the class 3 drugs, potassium channel blockers, in case of arrhythmia. And examples for potassium channel blocking agents are amiodarone, rondarone, sotalol, dofetilide, and ibutilide. Amiodarone, it is a main drug used in case of antiarrhythmia because amiodarone is the only agent that shows class 1, 2, 3, and 4 actions, that is sodium channel blocking, potassium channel blocking, beta adrenergic action, and calcium channel blocking. These all actions are shown by one and only amiodarone. Amiodarone, the main constituent of amiodarone is iodine. It contains iodine. This and that is similar to thyroxine. So as it is containing iodine, the main adverse effects of amiodarone are hypothyroidism and hyperthyroidism. These are the main adverse effects shown by amiodarone. It also shows adverse effects like pulmonary fibrosis, blue-gray skin discoloration, optic neuritis, and corneal deposits. These are the main adverse effects of amiodarone. And the most commonly employed drug is amiodarone because as it is having all the actions of antiarrhythmic drugs. Amiodarone is also a PGP inhibitor, para-glycoprotein inhibitor, same as propafenone and quinidine. And drondarone. Drondarone is employed next to amiodarone because drondarone is similar to amiodarone but it lacks iodine, whereas amiodarone contains iodine. So the adverse effects of drondarone does not show hypothyroidism and hypothyroidism. The drondarone is less effective because it shows death. It causes death. So drondarone is not commonly employed, and though drondarone shows less adverse effects compared to amiodarone, as it is causing death, drondarone is not commonly employed. And next, sotalol. Sotalol is also a beta blocker, and it is also employed in cases of potassium channel blocking. So sotalol also shows class 2 and class 3 actions. The next drug is sotalol. The next drug is dofetilide. Dofetilide, according to Lippincott, the dofetilide is defined as first-line drug of choice in case of patients with atrial fibrillation, heart failure, and coronary artery diseases. When a person is suffering with atrial fibrillation, heart failure, and coronary artery diseases, then we can give dofetilide as it is a first-line drug of choice in patients. And dofetilide is the only drug that comes under the pure potassium channel blocker, whereas amiodarone it also shows all the other classes actions. And rondarone it is similar to amiodarone. Sotalol it is also a beta blocker, but dofetilide is the only drug that is a pure potassium channel blocker. Ibutilide is also a drug of choice in case of atrial flutter, whereas dofetilide shows action in case of atrial fibrillation. These are the class 3 drugs, and the main drawback of class 3 drugs is ventricular tachyarrhythmia, torsades de pointus. And coming to class 4 drugs, those are the calcium channel blockers. Examples are verapamil, diltiazem. And this verapamil, diltiazem, this comes under the non-dihydropyridine calcium channel blockers. They show action against atrial arrhythmia, whereas class 1B drugs show action against ventricular arrhythmia, and these calcium channel blockers show action against atrial arrhythmia. This is the description about class 4 drugs. And others miscellaneous are digoxin, adenosine, and magnesium sulfate. And here we are studying digoxin and adenosine. Digoxin, it is a sodium potassium ATPase pump inhibitor, that is it inhibiting the sodium and potassium channels and thus reducing the sodium influx and potassium efflux in depolarization and repolarization respectively. Adenosine, the main action of adenosine is decreasing the conduction of velocity of action potential. As the action potential velocity is decreasing, it is increasing the refractive period. As the refractive period is increasing, the heart rate decreases. Thank you.